Dr. Andrew Browne is going to come present some of the work, and he's sort of taken this information and then applied it to some of the patients. And he is going to be talking about quantifying color vision in disease. Andrew?
Thank you very much, Chris, and thanks for arranging this awesome meeting. So I'm what stands between you and lunch, so I'll try and make it as expeditious as possible. So today I'm talking about that same assay that Kimberly just talked about, which was the cone contrast threshold and its use in clinical populations. So Disclosures, Conan Medical has given us some devices that we use, and those are the same devices that we use in the data shown in this presentation. So visual processing occurs, of course, as light enters the eye and hits the retina, and then, of course, it goes along the optic nerve, which divides to both hemispheres of the brain, and both eyes have an optic nerve, and then they cross over, and synapse in the lateral geniculate nucleus go through the radiations and go back to the visual cortex. And so this whole circuit is relevant for how we process vision, which of course includes color. Most of the time that we talk about clinical color vision evaluation, it's in the context of achromatopsia, people with deficiencies of color of a specific type, or people with optic neuropathies. So talking about color vision in the context of maybe retina or anterior segment glaucoma is not a very common thing that we do, but I'll show you some of the experience that I've had over the last year in evaluating color in our patients. So again, this is largely focusing on the retina, the orange tissue shown in that eye. So the retina real estate is quite valuable and very small. If we put a postage stamp next to a diagram of the retina, this is actually to scale. A postage stamp is about a third of our retinal area. It's a tiny, tiny area. And so this is a color picture of my eye here with the optic nerve, the blood vessels coming off of it, the fovea, and then the peripheral vision, which would be in the peripheral retina over here. The fovea, which is where the majority of our visual perception comes from, is also where color vision comes from. And so this 1.5 millimeter diameter circle in the middle of our eye is responsible for most of our vision. And if we take a cross-section through that 1.5 millimeter eye on the OCT, we can see the foveal umbo and the depression here, which is where we have this very high density information of light being converted into neurological signals. So 1% of the retina is fovea, less than that, and half of the information that gets back to our visual cortex comes from that 1%. If you want to know, have a scale idea of how big this fovea is, a fine ballpoint pen is about 0.5 to 0.8 millimeters in diameter. And if you draw that onto the fovea, it covers almost the whole fovea. So it's a really, really tiny piece of tissue in our body that's responsible for our visual acuity as well as a lot of our color vision. So the tests that we use clinically routinely every single day to measure visual function include, everybody's probably read letters in the chart, which is black and white letters, which is ETDRS and Snellen visual acuity. The visual fields are quantified on a display like this, but a visual field is white light on a generally slightly less white background, or blue on yellow, or yellow on blue. And then also the Amsler grid, which is a grid pattern which people look for changes in the form of their vision, metamorphopsia. And so if we project these onto the actual eye, we can see that the visual field tests a very small part of the retina. The Amsler grid tests an even smaller part of the retina. And actually, when you overlay the 2020 to 2400 letters onto the fovea, it's even a smaller area. But this is all black on white, or white high contrast visual assessment. And so if we look at the Gavin Herbert Eye Institute, that's what we would look like if we were testing the vision the way that we test our testing vision on a routine basis in our clinics. But we see the world in color, and so I think it's relevant to think very seriously about how it is that we measure vision. And so if we look at the anatomy of the fovea, which is in this red circle over here, we can see on histology that there are all cones, very tiny, skinny little cones. And if we come out to this blue circle, there are cones, but now they've actually changed shape. So they go from being really skinny to really fat, and in the periphery they become even more fat. And everything in between here are actually the rods. Adaptive optics allows us to see this in living subjects rather than having to take a histological sample. And so all of these very fine cones are highly packed and dense, and they're all responsible for our color vision in our fovea. Interestingly enough, the distribution is not uniform. In fact, in the central part of our fovea, there are no blue cones, and then the green and reds are distributed fairly evenly. So if we take a diagrammatic cross-section of the retina, we can see that there are rods and 3 different cone opsins. And in primates, these are encoded on these different chromosomes, where the red-green color blindness is encoded on the X chromosome, and the rod and the short wavelength opsin are on the 3rd and 7th chromosome. People often ask, what do animals see in terms of their visual experience? And so here are cross-sections of different species. Here's a zebrafish, where you can see that there are actually 5 different cones and rods as well. And then chicks have a different set of wavelengths that they see. And then you have mice and sheep, which have very few cones and a majority of rods. And then, of course, other animals as well, coming to the primates. So all of these animals here in the top and the bottom, these are these cone-dominant species, and then the rod-dominant species are typically mice and cattle, rodents and cattle. If you look at the distribution in these different species, they have, not all of them have a fovea. So we are unique in that we have a highly concentrated cluster of cones in the central part of our vision, whereas other animals might have a horizontal streak or a clustering of cones in the superior part of their retina. Of course, I'm most interested in humans because that's who I care for, but we also grow human stem cell-derived organoids in a petri dish in our laboratory setting. So we are looking to study cone sensitivity in these model systems. And of course, zebrafish as well, looking at their retinal structure and function and responsivity to color. So color vision testing in the clinic. Most people have probably encountered these color plates, which are testing for red-green color discrepancy or deficiency and blue-yellow. And typically there's maybe 8 to 12 different of these numbers that are shown to someone, and then they respond if they can see them. And this is a great screening tool for deficiency in color sensitivity, but not really very quantitative. The Farnsworth-Munsell is an arrangement test where colors are arranged across the spectrum of the rainbow, and then you look for errors in that arrangement. This test is quantitative, but it takes 20 to 30 minutes, so it's really not practical in a clinical setting. And then finally, the anomaloscope is a test where you compare the combination of green and red to a reference yellow and try to determine how much error there is between the combination of green and red to the yellow. But again, this is another 20 to 30 minute test that's not practical in the clinical context. So Dr. Jameson has already shown us how the cone contrast threshold works. It's very useful in this format because it's basically a highly calibrated computer screen that can control exactly how bright these different letter C's are presented to a patient, and provides a format in terms of the data presentation where you can see the individual sensitivities of the red, green, and blue opsins in human subjects in each of their eyes. So to validate this first, Clara Yu, who's a medical student at Western University last summer, made sure that we had a protocol that was appropriate for using this test. And so we tested human subjects in the clinic under various conditions, undilated, dilated, with varying degrees of optical filters, basically stronger sunglasses, and then through pinholes. And the pinhole is relevant because it's a way of neutralizing a refractive error, and we wanted to make sure that if we had someone with a high refractive error and we had them looking through a pinhole, that it didn't affect their color vision. So the data is as such, and so what we found was that the human subjects had normal eyes, needed to have an undilated state in order to have reliable tests. You can see with dilation, you have larger error bars, although still normal measurements in this gray area. As you increase the density of the filters, you of course have a decline in the sensitivity, but also when you look through pinholes, there's a lot of error and actually a deficiency or a borderline deficiency in color perception. So testing patients has to be in a non-mydriatic state using this cone contrast threshold test. And so I'll show you a variety of different disease states now. The first is going to be multiple sclerosis, which is a disease that can affect the whole visual pathway. And this is the condition that is most commonly associated with actually testing color vision in a clinical context. And then I'll show a variety of different diseases affecting the retina and how color vision changes in these diseases. So with macular degeneration and epiretinal membrane, as well as retinal vein occlusion, each affecting different layers of the retina in different ways. And then I'll show an example of how a cataract also affects color vision and how that changes after a cataract surgery. So multiple sclerosis is this demyelinating disease that affects the whole visual pathway. So if the visual pathway is affected at any point, it's hard to know exactly where it is just based on a single test like color vision testing. But because multiple sclerosis is the test where we routinely do show these color plates to assess color vision perception, this is a great starting point. And so in multiple sclerosis, there is early color vision loss, whether or you do or don't have a history of optic neuritis. And so the way that we wanted to compare the structure of the nerve with color vision was by performing an OCT, where we can look at the thickness of the nerve fibers converging into the optic nerve head. And we compared the findings from that with the findings from color vision testing. And so what we see here are we had 15 subjects with multiple sclerosis, 15 subjects who were normal healthy controls, age-matched. And we can see that there are patients who that were normal healthy had normal levels for each of their cone sensitivities. People who had, in these middle bars for each of the different colors, had multiple sclerosis but with a normal nerve fiber layer. And we can see that in the green and blue cones, there was a statistically significant difference between those groups. And then finally, in people who actually had an effect on their optic nerve, something that was measurable structurally, there was a much greater decrement in the sensitivity for each color. So, of course, we expect to see a color vision deficiency in multiple sclerosis because we've been using that as a screening tool for changes for many years. In macular degeneration, this is the #1 cause of vision loss in people over 50 in the US. And of course, we've probably seen many pictures like this where you have drusen throughout the macula, drusen underneath the retina, as shown on OCT. And the change that can occur is an ampular grid appears like this and can become distorted with decreased contrast sensitivity as well. So with different stages of macular degeneration, of course, this is a healthy eye. In early macular degeneration, you can have a few little punctate areas of drusen with some small drusen underneath the macula. In intermediate, we start to have many more drusen underneath the macula and distributed throughout the macula. And so someone may start to have decreased contrast sensitivity with macular degeneration in the early and intermediate stages. But visual acuity may not be affected at all. And then finally, we have advanced macular degeneration where you can have visual acuity loss, distortion, and so that has two different subtypes, atrophic or wet advanced macular degeneration, where you have complete loss of the photoreceptors, and then also wet neovascular macular degeneration, where again you have a loss of visual function. So these are the visual impairments where you would expect to see a change on ampular grid, where you would expect to see a change in visual acuity. And so here's an example of one of my patients, 94-year-old, who's had cataract surgery in both eyes, 2040 and 2020. Here are the images of his eyes showing many drusen, these little white flecks throughout the retina, an area of geographic atrophy in the right eye. But the visual acuity is actually quite good. And then if you look at the autofluorescence, we can see areas where you can see extensive atrophy around the fovea in this eye and getting closer to the fovea in the other eye. And so this, of course, is age-related macular degeneration. The OCT looks very different from normal. And what is this patient's color vision sensitivity? So as it turns out, he can see almost nothing with his right eye, which is apparently 20/40, but he can see almost nothing. So his experience of the world with his right eye is very different. And his left eye, which is seeing 20/20, great by our routine evaluation, is actually deficient in all different cone classes. And so when the patient actually says, when I look at these colored boxes with my right eye, they all appear black. So we looked at subjects with differing degrees of macular degeneration from early, intermediate to advanced forms and compared them to normal healthy age-matched controls. And of course, we see that in the intermediate form of the disease, there is a statistically significant difference in the blue and red cone classes. And then in the advanced form of the disease, there's statistical significance across all cone classes. And this confirms what is published last year by Ladd et al., demonstrating that intermediate macular degeneration is associated with a decline in color vision sensitivity, whereas we still cannot detect it on early phases of the disease. But all clinical trials at this point have been focused on wet and dry advanced forms of the disease. And we don't have metrics other than visual acuity that are routinely used to look at changes in visual perception. So it's truly seeing a difference in intermediate macular degeneration provides to us a new target for a clinical endpoint for measuring changes in function in the context of treatment or not. Retinal vein occlusion is a vascular disease, essentially a stroke of the eye, where you might have hemorrhages within the retina decreased blood flow in the superior part of this example of the retina. And on the OCT, you can have extensive swelling of the retina as well with a decline in visual acuity. Here's a patient of mine, 2060 when they presented, 2020 in the other eye. And after treatment, normalizing the anatomy as much as possible, they got to 2030, and in the other eye remained 2015 or so. And so the question was, how much color vision sensitivity did they have? So despite being 20/30, they had very low color vision sensitivity, whereas their other eye was a little bit closer to normal. So looking at 10 humans who had decreased vision in one of their eyes and comparing that to their fellow eye, we see that for the vein occlusion eye, in all cone opsins, there was a decline that was statistically significant compared to their fellow eye. Epiretinal membranes are a condition that we treat surgically, and epiretinal membranes is a proliferation of fibrocellular material on the surface of the macula. And you can see these blood vessels here being distorted. So there's mechanical stresses that are conveyed from this scar tissue to the surface of the retina. And these can be graded from stage 1 through 4, where you have increasing degrees of distortion of the normal macular anatomy. And so looking at epiretinal membranes and how they affect color vision and comparing them to control eyes, we see that there is a kind of heterogeneity in terms of which opsins are most affected. Certainly the red opsin is most affected in this group of patients that we had 34. In the more advanced form of epiretinal membrane, we have loss of the foveal contour. We had more green opsin deficiency. And then with a more advanced stage 3 epiretinal membrane, 2 cone classes were affected. So this may present to us an opportunity to try and quantify changes in macular function before and after epiretinal membrane surgery. Here's an example of one of my patients who has an epiretinal membrane, and you can see there's a clear difference between the two eyes in their sensitivities. So why is color vision affected in epiretinal membranes? We have a membrane on the surface of the retina. The photoreceptors are at the bottom of the retina. They're not directly in contact. And so there may be a variety of mechanisms. Could be through mechanical stress that are transmitted from the surface of the retina down to the photoreceptor level, or it could be altered waveguide properties of Mueller cells. And so Mueller cells are extremely interesting cells because they basically are fiber optics that live in the retina. And one of the phenomena known as the Stiles-Crawford effect of the first kind affects the intensity and brightness that one sees in the retina depending on the angle of illumination. So if you take a piece of retina out of a cadaver eye and you shine light on it, the amount of light that comes through that piece of tissue through the fovea it differs depending on the angle of illumination. So if it's perpendicular, all the light comes through. If it's at a 5-degree or 10-degree angle, less light comes through. So there's a very important fiber optic process that occurs of guiding light from the inner retina to the photoreceptors, and that could possibly explain some of the color vision changes that we see. This has also been validated in humans who were presented with stimuli at differing angles on this horizontal axis, and on the vertical axis we see their relative sensitivity. So angles of light coming from different angles can have a decrease or increase in luminance intensity. The Stiles-Crawford effect of the second kind is the chromatic variety, where you have incident light at 90 degrees, it's perceived as it should be, and if it comes at a different angle, it has a different color perception. So looking at the Muellers as a waveguide, if we extract Mueller cells and put them into an experimental apparatus, this was published back in 2007. This is an isolated Mueller cell. There's an optical source and an optical detector. And when the Mueller cell is aligned perfectly between those, the source and detector, you have almost all of the light being guided from the source to the detector. And when the cell is removed, again, the light's still shining at the detector, but it doesn't get coupled perfectly to the detector. So the Mueller cell is essentially acting as a fiber optic. The Mueller cells have also been shown in models to be coupled directly to the green and red cone class in terms of which cone class they favor to direct light toward. And this has been validated again, of course, in experimental models as well, where the red and green cone classes are most sensitive to Mueller alignment. Finally, Marjan Farid had a case last year where we had preoperative and postoperative cataract surgery evaluation of color sensitivity. Of course, we always hear patients saying, yes, the world seems so much more vibrant and the colors are so much more saturated. And so using CCT, we in this one case, studied how the patient's color vision changed, and we're planning to do a prospective study over the summer for both epiretinal membrane as well as for cataract surgery. So in conclusion, even in patients who have good visual acuity, 20/20, 20/30, 20/40, these cone contrast threshold tests reveal deficits, which we are ignoring in terms of how we manage patients and have clinical endpoints. And this is true for multiple sclerosis, epiretinal membrane, macular degeneration, and vein occlusion. And CCT appears to be an important clinical endpoint that we could use in clinical trials. But the main challenges that we experience from a practical standpoint of using it in the clinic is that it's a 7 to 15 minute test, and a lot of patients who are oftentimes older say it's a very challenging test to take. So our experience with the existing version of CCT kind of informs how we would look forward to designing new implementations for assessing color vision in our patients. Finally, I'll just touch briefly on an alternative way which is being presented now. And we're actually very lucky to have the Palczewski group having joined us, because there may be an entirely different way of probing color vision without using color light whatsoever, using infrared light. If anybody's ever looked at a remote control for a TV, you can't see the light flashing usually. And so that's because our eyes are not sensitive to infrared light. But what I'll describe to you now is a little bit about microperimetry and how microperimetry can be used for, infrared light can be used in microperimetry. So microperimetry is where you have the retina and cross-section here, and beams of light are shown onto very small focal areas. And so we create this map of sensitivity to light. And so, for example, over here, this is in the green area, and this focal point is more sensitive than this focal point over here in the yellow to orangish area. And so it's a way of probing very precisely different areas of the retina for its sensitivity. And so this is with the Palczewski group. They've developed a 2-photon microperimeter as part of the Audacious Goals initiative. And so what they've demonstrated is that with a test pattern being shown across the visible spectrum into an eye, if the pattern goes through a cataract, then there's a lot of diffusion and dispersion of light. And so the pattern is essentially lost. Whereas if it goes through clear media, of course the pattern is recapitulated once it gets through to the retina. And with infrared light, because infrared light tends to penetrate all tissues so much more easily than in visible spectrum, when it passes through a diffusion-like media like a cataract, the pattern is recapitulated, and it's very similar to the pattern that is seen without any diffusing media. So the question is, can we stimulate vision with infrared light? Well, we can't just normally with everyday light. None of us are seeing infrared light very much right now, unless there's a quadrichromat or multichromat that has visual sensitivity, and maybe gene editing in the future will allow us to do that sort of thing. But for now, we can't. And so conventional white light microperimetry does suffer from some of this diffusion, where larger focal areas of the retina can be stimulated. And with infrared 2-photon ophthalmoscopy, where pulsed lasers are directed to very small focal volumes and the infrared light itself is not dispersed, in principle one can very reliably probe small areas of the retina. And so what their group has shown is that as the stimulus wavelength increases, this is all in the infrared spectrum, about the sensitivity from this pulsing laser can be detected as a specific color. So here's the visible spectrum on the y-axis. And so people who are pulsed with infrared light on the 1.2 micron wavelength, they perceive light about half of that wavelength. So 1200 divided by 2 is about 600. So in principle, you can use infrared light of different wavelengths using these pulse laser sources to probe the retina very sensitively, and also stimulating each of the individual cone classes, possibly independently. So in terms of future directions, we do plan to continue to use cone contrast thresholding in clinical disease, and also in perioperative testing for cataract and epiretinal membrane surgery. The 2-photon visual function testing in patients with disease will be starting this summer. And I'm recruiting patients, and we're recruiting patients from throughout our clinic with varying different types of diseases. And we're also hoping to develop faster testing strategies for evaluating color vision, because I believe that it is something important that we shouldn't be ignoring in our routine clinical care. And I'd like to acknowledge the Institute for Clinical and Translational Science, who supports my salary and a lot of our work with stats analysis, Conan Medical for providing the devices, the medical students from here at UCI, as well as at Medical College of Wisconsin and Western University, who spent the summer last year. We were all working together to capture this data on clinical subjects. And then, of course, Chris Kenny and Kimberly Jameson and one of my partners, Mithil Mehta, Chantal Boisvert, and Wade Crow, who invited us to participate with their patient populations. And I'll take any questions. No, we don't have that population characterized yet, no. But I have had one patient who had macular edema, who did have an improvement in their color sensitivity. But I would presume that, in the context of macular edema or vein occlusion from diabetes, or macular edema from vein occlusion or diabetes, the color sensitivity is probably affected largely by dispersion by the fluid within the retina, rather than a true change necessarily in visual processing. But we may be able to answer that question actually a little bit more accurately with tests like the 2-photon infrared technique. Right, so right now we rely on things that are similar to the Amsler grid, looking for distortion and that sort of things, maybe a visual acuity decline, but certainly that's part of what we hope to do, is to develop more practical tools that probably are based on LCD displays, so anybody with their cell phone can evaluate their visual function. Yeah, that's one of the challenges in color vision testing, is that it's a non-localizing test, of course, starting at the photoreceptors, possibly to the different types of ganglion cells. Right now, there's nothing that I'm aware of in terms of looking at even magnocellular versus parvocellular projections, and even dividing that down even further to smaller groups. I think that when you start thinking about these other types of ganglion cells, we have to present maybe not necessarily static stimuli, but kind of dynamic stimuli to try and tap into those different processing mechanisms. Yeah, so certainly color vision testing is useful in diagnosis. In terms of clinical endpoints for treatments, for example, we look at intermediate macular degeneration, where visual acuity may not be affected. Of course, the OCT can be affected, but we're not really tapping into the patient's visual perception and experience. So right now, a lot of the trials that are dedicated towards dry macular degeneration are looking purely at structural changes within the eye, and not looking at changes or preservation of visual function. So from a clinical standpoint, using color vision as a way of preserving visual function over time would be the primary target. Using a test like the Color DX, you can, similarly to glaucoma progression analysis, plot progression of color vision decline. So, because there are really no other mainstream color vision assays in a clinical context that are quantitative, this in my mind is the lowest hanging fruit for us to kind of focus on.
And I think we're going to stop there. I'm sure there are more questions, but please ask them over lunch. And I want to thank all the speakers and all the participants.